Okay, welcome back. We're going to have a very short lecture today on diabetes, which certainly relates to the endocrine pancreas because of many of the causes and effects of diabetes have to do with the pancreas. So, diabetes is often referred to as diabetes mellitus. You'll see why in just a second. The word diabetes comes from the Latin for the word siphon. The patients that have diabetes show excessive urination, so the siphoning of liquid. So the official word for this is polyuria. Mellitus or mellitus means honey, so sweet. So think of glucose being sweet like honey. And therefore, when you put it together, diabetes mellitus means excessive production of a sweet urine. This is different from diabetes insipidus, insipid meaning not sweet. Diabetes insipidus has a completely different cause that has more to do with salt and water balance. Diabetes has been known for a very, very long time, since ancient times. Um, the symptoms were lots of a sweet urine that was produced and an emaciated body. A lot of sweet urine, high sugar in the blood. The sugar draws water into the filtrate in the kidneys, and so that's why you get the polyuria. And the emaciation is caused by a breakdown of proteins in the muscles for energy because glucose can't get into cells, so the body has to start breaking down whatever it can. The cells are starving for glucose, even though they're surrounded by it. There's tons of glucose in the blood, but it can't enter the cells, so they can't use it. So people have referred to diabetes as a condition called starvation in the midst of plenty. Your cells are starving even though they're surrounded by energy. Several things that are known for diabetes: polydipsia, which is intense thirst, and that accompanies the polyuria, which is the excessive urine production. And then in the late 1800s, they figured out that it was low insulin from the pancreas that caused diabetes. So this is just a graphical illustration of the medical cause of polyuria and polydipsia. Um, your glucose is supposed to be reabsorbed in the kidneys in the filtrate. You don't want to get rid of glucose. You spend all that time eating in order to get it. So the idea is that a healthy person doesn't secrete any glucose in their urine. But in the case of diabetes, you don't have any way to put the sugar away. The sugar gets super high in the blood, and the glucose transporters just get overwhelmed. They can't bring the glucose back into the filtrate, so glucose ends up in the filtrate in the kidneys where it's not supposed to be. And then because that's that brings water with it. Anytime you have a solute in high concentration, it's going to bring water along with it. So you end up bringing a bunch of water into the filtrate, and that's where the excessive urine comes from. So you have excessive urine that contains sugar. I'm going to go through just a little bit of clinical um, evidence that somebody has diabetes, and the graphs on the right are related to the things that I'm going to show you here. In a normal person, if they don't eat for about 8 hours, their blood sugar will usually go down to around 70 milligrams per deciliter, which is the units that they measure blood sugar in. 5.5 millimolar would be the units that you're probably more accustomed to, but in medical parlance, they use milligrams per deciliter. 2 hours after eating a meal that had a lot of glucose in it, your glucose will be back down below 200 milligrams per deciliter, regardless of how much you ate typically. So a glucose challenge in the doctor's office or just a big meal, even within 2 hours, your glucose should be back down below 200 milligrams per deciliter. In a pre-diabetic condition, which a lot of people are diagnosed first with prediabetes, at fasting, they only get down to about 110, 125 milligrams per deciliter, which is quite a bit more than the 70 that you'd see in a normal person. And in diabetes, at fasting, they're over 125 milligrams per deciliter. So a lot of times, the first time anyone's diagnosed with diabetes, they show up to their doctor's office. They've been fasting, but overnight, so they're told not to eat. They come in and they have a blood glucose a measurement of over 125, then they'll call that diabetes, which is around 7 millimolar sugar. 2 hours after a glucose challenge, they'll still be over 200 milligrams per deciliter, so they can't bring the blood sugar down after a meal or after a glucose challenge. Also, in diabetes, this is more clinically related, having to do with the treatment of diabetes. Uh, Diabetics are often in danger of being really, really low on their blood glucose, and that's as a result of insulin injections that they take. And so anything under 40 milligrams per deciliter is life-threatening and can be fatal with a hypoglycemic diabetic coma. You should remember that a person who has diabetes can go into a coma if they don't treat it, and that's called a hyperglycemic coma, and that has to do with the huge levels of ketones that build up in their blood. But they can also go into a coma after injecting their insulin if they overinject it and draw the blood glucose down too low. That's a hypoglycemic coma. With today's really great insulins that they have, a person who's diabetic who passes out is much more likely to pass out from low blood sugar as a result of overinjection than they are from high blood sugar, which would be completely untreated diabetes, which is rare in today's world to have completely untreated diabetes. So why is it bad? Well, without insulin, you can't get sufficient glucose into the tissues, even though you're hyperglycemic. You've got all this blood, all this glucose in your blood, and it can't get in. This leads to emaciation because your tissues start breaking down protein. Ketoacidosis, you build up a lot of ketones in the blood because the liver's converting molecules into ketones and producing that, and your blood becomes acidic. So that can be life-threatening. With insulin treatment, it's possible for you to have hypoglycemia due to overinjection, and that can lead to unconsciousness and death. So these are the extreme situations. An untreated person can get ketoacidosis, and an overtreated person can get a hypoglycemic shock. But most people keep it somewhere in the middle, and what you find with diabetes, with regular treatment, but maybe not managed as well as it could be, high blood sugar leads to all kinds of cardiovascular issues, especially micro blood vessels, the ones leading to the retina of the eye, the ones leading to the feet, and so you end up with um, side effects that are pretty serious: blindness due to the problems with the retina, and a loss of feeling to the nerves in your feet, which leads to injuries that go untreated, which can then lead to gangrene and amputation. So um, you have the two extremes, which you can die from: untreated diabetes, you die from ketoacidosis and a hyperglycemic coma. Overtreated with too much insulin, you go into hypoglycemic coma, and that can lead to unconsciousness and death. But the vast majority of diabetics are in the middle. They're treating it, but maybe they're not treating it quite well enough, and their blood sugar stays high a lot of the time, and they end up with these problems with retinopathy, neuropathy, and problems with blood vasculature to the, especially the feet. So it's just bad all the way around. Treatments for insulin deficiency, the classic treatment, 1,000 years ago was starvation. They found if they didn't feed the person, they didn't have all the symptoms of the hyperglycemia. But obviously, you can't maintain that very long. Ketoacidosis is a big problem for type 1 diabetes without treatment, and it can lead to a hyperglycemic coma, as I said before. You can smell ketoacidosis on a person's breath. Their breath smells like acetone, smells like a kind of sweet and fruity smell that they have. 20th century treatments, they started extracting from the pancreas in the 1920s. Banting and Best won a Nobel Prize for this, for learning how to extract insulin from pancreatic extracts. And many other people were working on it at the same time. So they learned how to get it from cows, pigs, sheep, and treat people with it. And it was huge. I mean, there was no treatment for, basically people died when they had diabetes until they got these treatments, and they showed that they were able to reverse the negative effects of diabetes very quickly with these. The only problem was that these are not your insulin, and your body eventually figures out that you're using the wrong insulin. They're not, identical between species, and so you start building up antibodies. So if you use bovine insulin for a few years, you would develop antibodies against it, and if it became ineffective, then you'd have to switch to porcine. And if that became ineffective, you'd switch to ovine. Not necessarily in that order, but you get the idea. Because it wasn't your insulin, it was insulin from another species, obviously. And these weren't pure preparations. There were spears they could get with the technology at the time, and they had to be refrigerated um, all the time. They did not last very long, and so people ran out of insulin all the time. So it wasn't the best, but it certainly saved many, many, many lives and allowed a near normal life. Diabetics still had a shorter lifespan, but they could lead a significantly long life anyway. They would usually end up with the various apathies, though, retinopathies, neuropathies, and circulatory system disorders. Very much higher incidence of cardiovascular disease and stroke than the normal population. But at least it wasn't a death sentence to find out you were diabetic. When you talk about diabetes today, you hear people talk about type 1 versus type 2. Um, in the past, they called it insulin dependent and non insulin dependent. That's not necessarily the way they refer to it these days. They have very different causes and very different treatments. And so about 10 million of the people in the U.S. have some kind of diabetes, which is pretty high given we have, what, about 300 million people in the U.S. So it's pretty high incidence. Type 1 is juvenile onset, and which they used to call insulin-dependent diabetes. Um, it's 5 to 10% of the population has some type of type 1 diabetes. Usually comes on as a juvenile, as the name indicates, and it's not infant. It usually doesn't come. There's two times during your juvenile. There's a kind of early juvenile, 8 to 10 years old, and then there's a later juvenile, like 12 to 14 or something. I don't know the exact, but there's a couple of times that you're likely to get juvenile onset diabetes. Type 2 diabetes is often called adult onset, but in today's world, especially in the United States, with all the obesity we have, it's not being restricted to adults anymore. Children are getting it. So it's over 90% of the diabetes in the United States. They call it non-insulin dependent because it's not always. It's more often treated with things other than insulin, whereas type 1 diabetes can only really be treated with insulin. So type 1 diabetes mellitus is due to a loss of beta cells in the pancreas, which leads to a complete loss of insulin production. This is an autoimmune disorder, one of the many autoimmune disorders that we have that seem to be increasing in the world. I'm not sure why, but Western countries seem to have a lot of autoimmune disorders, and they seem to be increasing. Beta cells are attacked by cytotoxic T cells, which have decided that your beta cells are the enemy. And so your own immune cells are attacking your beta cells. They completely destroy the beta cells. People who have the beta cells attacked also have an increased risk of these cytotoxic T cells attacking the thyroid and creating thyroid disease that we talked about previously. The risk factors are kind of relatively weak in terms of you can't point to one thing that causes it. Cold weather, because it may be stimulated by a viral situation where a virus comes in and stimulates these autoimmune cytotoxic T cells, and viruses are more associated with cold weather. So people who live in colder climates have more of this than warmer climates. Infections, again, since viruses may be a transmitting agent for stimulating these T cells to attack. And then genetics, there is a slightly higher rate of diabetes, type 1 diabetes, among people who have other people in their family with it, but it's not a seriously strong link. It's not like if your brother has it, you're going to have it or something. It doesn't work that way. Symptoms we've talked about: polyuria, excessive urine production; polydipsia, excessive thirst; polyphagia, excessive hunger; weight loss despite the polyphagia; high plasma glucose levels, low insulin, and obviously glucose in the urine as well, and very low insulin levels. The treatments are insulin. That is the main and primary treatment for diabetes mellitus. Diet, exercise, and other things are good. I mean, in other words, to mitigate the other effects, especially cardiovascular disease and heart disease, it's better to stay thinner than fatter. Exercise just keeps you healthier, keeps your circulatory system going better, and prevention of the negative effects can at least mitigation of them Better insulins and better delivery methods have led to better management of blood sugar and overall better health for type 1 diabetics. Um, the insulins have gotten really good. Um, I'm type 1 diabetic. I'm sure I mentioned it before. At least one member of the current endocrinology class is type 1 diabetic. Um, so it's just not that unusual to run across people who have this. Um, the insulins have become recombinant now, so instead of using pig or sheep or pork, I mean pig or sheep or cow, um, you have recombinant insulin. The first one that they came up with was the exact copy of the human insulin called Humulin. And then they started messing around with some of the amino acids, and they found out, hey, if we put an aspartate group here instead of the normal one, or if we put a different group here, we can increase the half-life in the blood. We can make it more powerful and whatnot. So most people have at least two insulins. I mean, I have two different insulins. One for when I eat, and that's a very rapid-acting insulin, uh, and but with a very short half-life. Got a 2-hour half-life, or shorter even. You take it about 15 minutes before you eat and put your blood sugar away, and you do great. But all the rest of the time you're in a fasting mode, and type 1 diabetics continue to produce glucose even when they're not eating. They have a lot of gluconeogenesis from both the liver and the kidneys. The kidneys keep reabsorbing glucose at levels that they shouldn't. So you end up with glucose in your blood even when you're not eating. So you take a second insulin, a weaker acting but very long lasting 24-hour half-life insulin. And so the short one I take is called Novolog, but it's called insulin aspartate because it has an aspartic acid substitution somewhere. And then the other is called insulin glargine, and the one I take is called Basaglar. But each company has a different name for it. This is very slow acting. It's very clumpy. It doesn't enter the body very quickly after you inject it, and then it hangs around for up to 24 hours. So you got one insulin taking care of when you eat, and one insulin taking care of you the rest of the time. And between the two, you can really keep your blood sugar down. But the risk of overinjection, I overinject all the time. I can feel it. I think most diabetics can feel it. When you start getting below about 60 milligrams per deciliter, you just don't feel right. You feel agitated and irritable. My wife said she couldn't tell the difference. I'm always agitated and irritable. But cortisol levels start to go up, so you feel that agitation associated with cortisol. Epinephrine starts to go up. You feel that kind of fight or flight kicking in a little bit. And then your vision starts to get a little weird. And it looks like a bad cable TV, kind of pixelated and whatnot. So I know when I'm going low. And you just have to make sure you always have I always try and keep some kind of sugar around. I keep some glucose tabs, but I also keep energy bars or something that I'd rather eat than a glucose tab in case I overinject. There are newer treatments. A lot of younger folks are putting in. They have monitors now that'll monitor your blood glucose. They have pumps that'll provide you the insulin when you need it, more like your pancreas does. They have pancreatic transplants, islet cell transplants, stem cells. All of these they're working on. Right now, though, most people are taking some kind of form of insulin. I think number one is injectable insulins like I do. Number two, for younger people especially, because they're going to have to do this their whole life, are the insulin pumps. Um, there's cell phone programs. You can put a little patch on your arm, and you can put your cell phone up to the patch, and it'll tell you what your blood glucose is, so you don't have to be sticking your fingers all the time. It's getting better. It's getting better. It's not horrible to be type 1 diabetic anymore. You can pretty much live a normal life as long as you stay on top of it. The number one, other than plasma glucose, which usually measured by a finger prick, or like I said, these cell phone methods that they have now that measure it. But the way that most people monitor how well they're doing is through a blood test that involves looking at your red blood cells, which bind sugar relative to how much sugar is in your blood. And there's a metric there that you can use that says, okay, I'm doing really good or I'm doing really poorly at monitoring my blood glucose. And it's a 3-month window for that because your red blood cells hang around for about 3 months. So it's a really nice metric that a lot of us use. Type 2 diabetes used to be called adult onset, but like I said, with the increase in obesity in today's country, a lot of children are now starting to get, at least older children are starting to get type 2 diabetes. The symptoms, again, are polyuria, polydipsia, polyphagia, high plasma glucose, but insulin can be either high or low depending on which type of type 2. Type 2 diabetes is not a single disorder. You have to look at the patient and look at their individual parameters for diagnosis and treatment of that. It can be asymptomatic where you don't even notice that you have it. Maybe you're just marginally diabetic. But over time, all the causes, all the things that go wrong in type 1 diabetes will go wrong in type 2 diabetes. Retinopathies, neuropathies, and cardiovascular, and definitely a much higher rate of cardiovascular disease and heart disease. So it's not something to take lightly. It leads to increased heart disease and stroke. Is the number one killer in type 2 diabetes is heart disease and stroke. Seems to be a disease of obesity for the most part, and it can be very well treated with diet and exercise. And then there are drugs to treat it as well. A primary characteristic is often insulin resistance, which seems kind of weird. So you make insulin, but your body doesn't respond. It's an inability of target cells to respond to insulin. And obesity is the most common risk factor for insulin resistance. It can result from some combination of the following. The liver, the adipose tissue, skeletal muscle cells no longer respond to the insulin, even though insulin is produced, often because the receptor for insulin is desensitized. And also sometimes the second messenger cascades downstream from the receptor are also downregulated. This is just from having too much insulin too much of the time. If you eat all the time, if you're just constantly eating a whole lot and you're eating large meals, you're producing a ton of insulin. That insulin is being seen by these cells and they're going, okay, I'm going to downregulate. I've told you about downregulation before with the beta adrenergic receptors downregulated in the presence of too much epinephrine. There's something in the blood that targets insulin sometimes, an antibody, so the insulin can't bind the receptor. That's a totally separate cause from the first one. Our insulin is not properly released from the beta cells, and this occurs usually secondarily to insulin resistance. So those are 1 and 3 are kind of related there. You have constant hyperglycemia, and this causes desensitization of the beta cells. They stop making insulin. But there's a progression to this. And then there are other defects in insulin production of the secretory machinery that could cause type 2 diabetes. But obesity is the number one causative agent of type 2 diabetes. The hypothesis is that adipose tissue, the fat tissues, can only put away so much fat from glucose, and you finally just kind of run out of the ability to do that. So if you can't put the glucose away into the fat tissues, you end up with hyperglycemia. The high glucose causes more insulin to be produced, and this causes hyperinsulinemia, and the high insulin causes downregulation of the insulin receptor, so you become insulin resistant. Treatment depends on whether or not you have too much or too little insulin. Only the doctor can determine that. But regardless of what type of type 2 diabetes you have, diet and exercise would be the treatment. It's very effective when it's used. Excuse me. And the problem is, people don't want to go to the doctor and have the doctor tell them. It's like telling you to quit smoking. Nobody wants to hear it, even though they know it's correct. They also don't want to hear that they need to lose weight. So they want to go to the doctor and get a pill and make everything all better. I'm sorry, but it's real. So doctors are loath to prescribe diet and exercise, even though that is the prescription. Instead, they end up giving you a pill. But really, if you have type 2 diabetes, the main thing to do is to lose weight. And these other things will help while you're trying to do that. Excuse me. The number one treatment for a long time, and they started using this in France in the 1950s. It took about 30 more years before the United States started using it, is a drug called metformin. And it decreases hyperglycemia by decreasing gluconeogenesis. So it acts on the kidney and the liver, the two places where there's only two places that do gluconeogenesis to any extent, and that's the liver and the kidney. And it attacks that gluconeogenic pathway and keeps you from making glucose from scratch, from amino acids and other circulatory agents. circulating agent. It's often combined with other drugs to decrease glucose absorption from the kidney, so the kidney keeps um, secreting glucose instead of reabsorbing it. It increases sensitivity to insulin or help muscles absorb glucose. These other drugs do. You can use them along with metformin, but metformin is like I think it's the number 4 prescribed drug in all the United States. It's a blockbuster 78, $80 billion a year drug or something. It's so a lot of people take metformin. It's probably the number one thing. The doctors like to prescribe things that don't have a lot of side effects, and metformin has very few side effects relative to other things. So there's these things. I won't go into the details, but these DPP4 inhibitors, the commercials for these are out all the time right now. Januvia helps you make insulin from your pancreas without resulting in so much insulin that you get hyperglycemia. So it puts you back on kind of on the normal track. Januvia is a great drug if you really are going to diet and exercise and you take Januvia at the same time. It'll help you lose the weight, and um, you will get better, and you'll feel better while you're getting there. Then another one that's on commercials all the time is Trulicity. It's a glucagon-like peptide agonist, so meaning it does what glucagon does. It increases beta cell growth. It helps regulate insulin use, slows stomach emptying, just kind of makes you process foods better. And then there's a whole number of other treatments. There's so many people that have this type 2 diabetes that every pharmacological company, every pharmaceutical company is producing a drug. But let me be honest, diet and exercise. That's the way to. The main treatment for type 2 diabetes should be diet and exercise. The main treatment for cardiovascular disease and heart disease should be diet and exercise. It's just Americans would rather take a pill. All right, well, that's pretty much it for today. I will have another short lecture posted up soon.